Mariam Aljneibi, one of the R3 emergency resident. So I'm gonna start my grand round today with a case. So we had a 27 years old female who presented to the emergency department with a history of shortness of breath, dry cough, and pleuritic chest pain for 5 weeks. So she's not known to have any past medical history. She has no allergies, and she's not taking any medication. So initially, 2 weeks ago, this patient presented to the emergency with the similar symptoms. She had a dry cough, shortness of breath, and she was found that she's sitting at 84% of room air with some sort of wheezing on examination. She was treated with oxygen and bronchodilators, and then she started to be better and started to be sitting at 97 in room air. So she had an X-ray at that time, which showed that, as you can see here, there is like a patchy heterogeneous opacification bilaterally. Otherwise, like there is no pneumothorax, no other findings. The heart looks normal. There is no fractures or any kind of things. The physician at that time ordered a CT chest because he was suspecting that she, like a female, young, at 27, sitting at 84% in room air, which maybe she had a PE. So he ordered a CT chest to make sure that he's not missing any pulmonary embolism. But the CT scan at that time showed that she has a grand glass opacification bilaterally and especially in the upper loop. So she had a blood test which shows like a WBC of 24,000, and she had a CT chest which shows no PE, just the findings of the bilateral upper lobe grand ground infiltrates. Other than that, she was discharged home on some bronchodilators and 5 days course of azithromycin, treating her atypical pneumonia. Today, she is presenting again with worsening cough, shortness of breath, and again with pleuritic chest pain. Her temperature is 36.8 and with a blood pressure of 109/74. Her heart rate is 102, so she's a bit tachycardiac with a rest rate of 20. And she was sitting at 93% on 6 liters of oxygen when she presented at this time. On examination, she was found hypoxic with some sort of crackles and wheezes on auscultation. So they got an ABG with the FiO2 of 40%, and this is her ABG. So her pH is 7.28, her PaCO2 is 52, PaO2 is 64, and bicarb 24. Anyone from the R1 would volunteer to interpret the findings of the ABG? Any volunteer?
Yes, I'm Hamid. I think it is a bit acidotic, acidosis, but there is no metabolic compensation.
Okay, what kind of acidosis?
Respiratory acidosis, but there is no metabolic compensation.
Okay, which is right. So as you can see here, she's having a bit of respiratory acidosis with no, not yet metabolic compensation. Her white blood cells actually, this time it's 23,000 with 18% of eosinophilic in differential, on a differential. So at this point, what is your differential diagnosis and what other things that you would like to know more? And is there any tests that you would like to add to know what's going on? Actually, I can't see the chat, so I would like to hear from you guys.
I'll read out anything that comes up in the chat if someone is willing to post a differential. COVID.
Possible, yes. Any other differential? Any other tests that you would like to do, maybe to know what's going on? Especially like she is a young female.
Someone else suggests CHF, PCP.
Okay. So PCP, one of the differential, I would say it could be possible because she is young, and like she's like hypoxic, so immunocompromised or PCP in general like would be a good differential. CHF, I mean, we looked at her chest X-ray initially. We don't see like any pleural effusion. The heart looks normal, so I would say it's less likely in this case. So I'm just gonna move on if there's no other answers for now.
Any travel history?
So no, she did not travel actually. No travel history. Okay, so let's just review some of the differential diagnoses. I'm gonna start with the lungs. So as I said, like initially she has no history of trauma, or so like there's no, I mean, pneumothorax is less likely or unlikely. Maybe now she's presenting with asthma or COPD exacerbation, but she's 27. It's less likely that she would present at the first time at this age. Infusion on which can be excluded as well because like we did not see anything in the chest X-ray, although that she has some sort of crackles on examination, but it's still like it's a possibility. No history of aspiration, so this is unlikely. Could it be a liver hemorrhage? But a young female, why she would have this? Is she having like any other rheumatological condition that would make her to like bleed in her lungs? So it's still a possibility. ARDS, not yet. Pneumonia is still a differential at this point, especially with the bilateral infiltrates and especially with atypical pneumonias. PE is not a diagnosis in this case because it was ruled out when she had like a CT angio, which would be less likely to present a couple days later with the PE. In terms of her like heart, in terms of like heart differential diagnosis, usually young patient would not have any of these unless they have like a congenital anomalies, or they might have something which happened that make them to present initially with this kind of presentation. Like for example, if a patient is taking cocaine, they might have like a first onset of MI or arrhythmia. If they're taking any kind of drugs, which is in general like toxin in general, will lead to this kind of presentation. Anemia, so her hemoglobin was normal, so it's unlikely as well. She has no history of like CO or cyanide tox. And going and lastly to the respiratory alkalosis causes or the metabolic acidosis causes, we saw her ABG, which we said like she's most likely having rest acidosis, which could be like because she's hypoventilating, and it could be because she's hypoxic as well. So she had more investigations. She was admitted to the hospital at this time. She had more investigations just to make sure like what they are missing. So her urine streptococcus and Legionella antigen were negative. She had a serum mycoplasma antibody where it was negative. TB, it's one of the differential diagnoses, especially with the upper bilateral lobe infiltrates, which turned to be negative. HIV were negative as well, because we said like maybe a PCB can present at this present like this, and giving the fact if she presented like this, we need to rule out immunocompromised, which is the HIV, from HIV. So, in further history, this patient revealed that 3 years ago, she started to use e-cigarette, which called vaping. So initially, she was using nicotine and THC products. When she presented earlier in the emergency department, 2 weeks ago. And before that, she was using nicotine and THC. Later on, when she was discharged, she went back and she switched to use gel pods. And we will talk about these two things later on in my presentation. So what this patient had is called EVALI, which is the e-cigarette or vaping product using associated lung injury. So this patient, or why I chose to talk about this topic specifically. So I'm not sure like how many of you know about this epidemic, and any of you just like from curiosity had a case so far until now. Anyone?
Nothing in the chat.
Okay. So I would assume that none of us saw a case until now. So this epidemic actually happened exactly before COVID started in November 2019. So I would say like there is like it was announced and then COVID came, so it took over, which was like a new thing for all of us. So that's why I wanted to just share it with you to have like a bit information about what happened before COVID exactly. The other thing is I chose EVALI because we are emergency physician. We see multiple presentations, multiple diseases with different presentations. So in terms of some presentation will mimic other presentations. So we need to have I would say one more things that it could be in the own differential diagnosis, especially when we see young healthy people. And the other thing is this disease could be preventable. How? Because EVALI has been started like a few years ago. E-cigarettes have been started a few years ago, but this disease has started. It has to happen like only last year. So there's something happened in between that led to this this disease. So it's kind of like preventable. So we need to be we need to advocate about this disease if we can. I'm gonna just go through what is vaping. So vaping, it's an act of inhalation and exhalation of aerosol, a product using the vaping products. So it's which called the e-cigarette. So as you can see here, like there's a mouthpiece, there's like the tank or the reservoir where you can put the vaping liquid, the heating element, and the battery. So it's like handy, like it looks nice. Teenagers, especially teenagers, would maybe it's easier for them to have it, and it comes in different type and prices. So this is what's called the e-cigarette, and there is another type which is this one here, which you just change the upper part of the e-cigarette with the liquid here and the heating system inside, and you can just inhale it. They inhale from the mouthpiece. What does it contain? Basically, there's like two types of, or I would say there's many types of e-juices that can be used. There's the regular e-juice, which has the nicotine with different concentrates and flavors. And we have the other e-juices, which is the modified ones, which tend to be used in the last year, mainly from teenagers. So it has the THC, which is tetrahydrocannabinol, and it contains some nicotine, vitamin E, and the cannabidiol oil as well. So it varies actually. Like some of them would have only THC, some of them would have only THC and nicotine. So it depends on the preference of the user. So going back to the gel pods that this patient used. So as you can see, like it comes with different flavors. So it's kind of like commercial thing people will get attracted to, because like you can choose whatever you want and whatever flavors you would like to try. And so that this patient used this after she was discharged from emergency at the first time. So what does gel pods contain? So it contains many things, like many chemical products, and it has some nicotine in it, and some flavors as well. So going just a few points on the how it works. So as I said, like they put the liquid, it get heated, and they inhale it and exhale it, and it's like a cigarette. So we just the liquid, which is the main point here, where they change in terms of like compared to the normal cigarette. So let's talk about the pathophysiology of EVALI, like how this happened. Basically, it's a new disease. So until now, they think that it's a spectrum of diseases processes, which is not only one disease. So some patients will present with acute eosinophilic pneumonia, which is most of them. And you can see, as you can see here in the CT scan of the chest, it can happen as bilateral infiltrates. Some patients will present also with diffuse elevator hemorrhage. That's why in my differential diagnosis I said, could it be like she's bleeding in her lung, or it could be something else. So it's one of the spectrum that those patients can present with, and to be honest, they don't know why. The other spectrum, or the other term of diseases that they can present with, is the lipoid pneumonia, which is kind of like cholesterol infiltrates, or fat infiltrates into the lung, which could represent EVALI. And the other thing also they can present as this interstitial lung disease, which in this term it can be hard to differentiate between a new onset interstitial lung disease, or if the patient already has it from before. The confusing part is how those patients present actually. So those patients would present mainly with respiratory symptoms such as cough, shortness of breath, chest pain. But some of them would present with GI symptoms like nausea, vomiting, abdominal pain, and diarrhea, which I would say like it's a bit like it's a very like broad, and we as an emergency physicians would be okay. So how many times I need to think about EVALI, and if I saw a patient presenting with these symptoms, it's just to put in your mind that they can present at any type or at any form. So going back to the history, so vaping or e-cigarettes were started since 2007. Until since that time until 2019, there were like no issues with the products using in the e-cigarette. But recently, last year, 2019, in November 2019, the CDC announced an epidemic in the US about EVALI. And it started initially in California. So I'm just gonna go through some of the case series, or the case numbers that has been found so far. So until January 2020, 2,807 cases were reported in the US, and they found about 2.4% death rate in those cases. 66% of those cases were male, where there are 34% females who were reported. Most of them were above 18 years old, but there were like 15% of those patients who were less than 18 years old. So as you can see, like it's a bit I would say like a bit high number, like compared to the adult part. So 2022 cases, upon questioning those patients, so 2022 cases, some of them, I mean, most of them reported that they use the THC containing products. 33% only use the THC products on like 33% use only THC products. While in the other hand, like 57% of those patients use the nicotine containing products. Only 13% use nicotine exclusively in their e-cigarettes. Let's talk about Canada. So as you can see here, the last information has been reported. It was in February in 2020. 20 cases were reported actually in Canada. Most of them, unfortunately, were in Quebec. So there were like 6 cases reported. Other than that, like there were 5 cases in British Columbia, 5 cases in Ontario, 2 cases in New Brunswick, 1 in Alberta, and 1 in Newfoundland and Labrador. There were like there was like no death rates until now in Canada, and most of them again like were males at a rate of 60%. 25% were below 18 years old, and the rest were above 18 years old. So from the 20 cases, basically 5 patients only presented with respiratory symptoms, while the other 15 cases presented with respiratory and GI symptoms. So again, like coming back to this point, like you would say maybe they would have other things than EVALI, but the point is how we diagnose those people, and we will get into that point. 16 patients were required hospital admission, and no deaths had been reported until now. So just to know what did they use so far? So 55% they used only nicotine, 25% uses THC, and 0.05 they only use the flavored vaping liquid, like without any chemicals. And 15% use nicotine, THC, and other substance. I'm gonna go also through like 2 case series where which were reported this year. So the first one is it was conducted in Illinois and Wisconsin. It has they reported about 98 cases. 89% reported having using THC products. 95% of these patients get admitted to the hospital, with a rate of 26% who were intubated and was put on mechanical ventilation, which I would say like it's a bit like quarter of those patients has been intubated. There were also another case series which was in California. About 156 cases were reported. 83% of them used also THC products. For 46% were admitted to the ICU, where 29% also required mechanical ventilation. So it's kind of like significant number of patients who were required like a mechanical or like a respiratory support. Actually, this is one of the articles or one of the studies has been done so far to look at what could be the cause of EVALI so far. So they conducted about like 99 patients, healthy patient, and where they found that about 51 patients has EVALI. So they went back to and they asked them like, what did you use in the last 90 days? So they found that most of them used THC product only, or the dual of nicotine and THC products together, which would say, which as you can see, like they have like a higher percentage of this patient who had EVALI at the end. So just to go back to what we need to do for those patients. So any patient presenting to the emergency department with some sort of hypoxia, shortness of breath, will need to get an X-ray as a baseline. If the physician at that time suspected that they might have some severe hypoxemia or severe hypoxia, they can still do the CT chest just to make sure that they are not missing any kind of like P, COVID, any other diseases. CBC with differential could help, but it still can't confirm the diagnosis. If the patient presented in a season where like influenza is there, so get an influenza test. And also like now COVID is one of the things that we need to consider and to rule out as well, especially that it has like similar kind of presentation and similar kind of like symptoms. Um, the one of the things that they found so far that it can not confirm, but it can tell us that, okay, this is EVALI, is the bronchoalveolar lavage, which they can take a fluid and then assess it. And they found so far they have like a high eosinophilic count, which could represent eosinophilic pneumonia, which is the caused by e-cigarette. So the treatment for those kind of presentation, those kind of diseases so far is corticosteroids. So they had a trial like treating those patients with antibiotic and steroids or steroids only. So far, what it worked is corticosteroids. It's either given by orally or giving intravenously. So you can still give it to the patient with help from our pulmonary, pulmonary from the pulmonary team. Other than that, antibiotic can be given if you're suspecting that this patient could be like community-acquired pneumonia. Otherwise, there is no rule that it can treat EVALI. So this patient, actually, the one that I discussed earlier, she was treated with oral prednisone for 5 days. And then she was also treated with oral doxycycline. But the main thing that helped with her prognosis were the steroids, because initially she was starting antibiotic, she came back with worsening symptoms. So we would assume that it did not help. So EVALI in general, it's a diagnosis of exclusion. And why I'm saying that, because we need to make sure that this patient is not having any sort of infection, cardiac disease, any neoplastic or rheumatological causes. So in that term, the patient needs to have pulmonary, like when you get a CT scan, they need to have a pulmonary infiltrates in their imaging. The other thing, going further with the history, and noticing that they used electronic nicotine delivery system or e-cigarettes in the previous 90 days would help in diagnosing EVALI. And as I said, like you always need to exclude other causes that can lead to this kind of presentation. One of the things that also would help in terms of diagnosis is the presence of eosinophilia in the peripheral blood test. Take-home message. So whenever you ask a patient about smoking history, always ask about e-cigarettes, using e-cigarettes, and what kind of things that they used so far, especially when they present sick like this. EVALI as a disease, or it's a diagnosis of exclusion. So rule or other things, and then put it put it in one of your differential diagnoses. But it's always a diagnosis of exclusion. Consider giving steroids on those type of patients, especially if they look sick. I mean, other way, like if they're presenting with COVID or Valley, both of them would benefit from it. And vaping nowadays, it's a public health issue, so we need to have some advocacy to the population. Do you have any questions so far? So I'm not sure if that give you a new head of information about what happened before COVID.
Christine asked a question, does vaping increase the risk for COVID?
It's a good question, actually. So to be honest, I don't know, because I mean, all the literature I went through were like either like they're not related to COVID or they have, I mean, this happened before COVID, but assuming that if they have a lung damage from the vaping, I mean, if they had COVID later on, it would worsen their prognosis, because I mean, the lung tissue is not good or not viable so far. So when they would have COVID, I mean, this gonna make their prognosis worse than expected. Any other questions?
And Sophie asks, was there a formal report, patient information released to Santé Publique? Sometimes young patients are hard to convince.
You mean like if they present it to you and they still want to use the same product that they used to?
I don't know, Anne-Sophie, do you want to clarify your question?
Okay. Can you hear me now?
Yes.
Okay, hi. No, my question is like some young people have had bad experiences with people like smoking weed or with like the hyperemesis syndrome, where they just don't believe you because you're just a doctor and you have to say it's bad for you. So I find it useful to have like formal information to give them where they can actually go and read and see that I'm not just saying anything. If that makes sense.
Okay, yeah, I got your point. So I think there is like some leaflets that they can share with them. The CDC website has some of them, and also the Canadian I mean health website, they also have one. I can share it with you if you would like to. I mean, it's very useful, like to the point, and like it shows them like how important to just to choose your, I mean, you can still use the e-cigarette, but you need to choose what is better for your health.
Okay, so Josh, our tox expert, is offering to give us some comments as well. So Josh, if you want to tell us your
presentation, Mariam. I think a lot of that information was very pertinent. I think the challenge in the emergency department, especially for people who don't, act in a public health role, in a poison center role that concentrates a lot of these weird, wonderful cases, is figuring out what the pretest probability is of a person with EVALI or with the rare disease. And in this case, it's exceedingly rare. I think the significance of this is, it's good to note in the sense that this was an example of a public health instrument being critical in detecting, defining, and then playing a role in treating this disease. But ultimately, the significance, I feel, is historical, as in a single event brought on by many different producers of likely THC-containing illicit vape products that learned their lesson the hard way. Because, drug dealers, they're smart people. They're out for profit, not to kill people. And the consensus, I think, within the toxicology community is that the vitamin E acetate is the culprit rather than nicotine alone containing, vaping quote unquote solutions. And the reason for that is thought to be due to, high concentration THC being visibly detectable by shaking around the pods, as in it's very viscous, very tenacious. You can tell by how many bubbles, how big they are formed, how likely it is for an illicit product to contain high concentrations. And vitamin E acetate, you know, on its face, you look at the name, it seems like an antioxidant, seems healthy, seems good to include, and it's incredibly tenacious as well. So when you add that as an adulterant, it led to a lot of people to perceive maybe the concentration of the THC to be higher than its actual concentration in people who bought these illicit pods. The issue with the steroid treatment is that there are no good data. You say ask your pulmonologist, chances are your pulmonologist is going to be asking the toxicologist. And, unfortunately, I was in the room with many of the toxicologists who came up with these guidelines, and it's based on very little to no data, right? There are no clinical trials to establish the efficacy of inhaled versus systemic versus kind of no steroid treatment. There were no control groups done. And you can chalk that up to the difficulty of, you know, arranging these kinds of studies in multiple different hospitals with multiple different IRBs dispersed in time when things are still arising. But you know, it should cast a shadow of doubt on this guideline for treatment, in addition to all the other guidelines you see in emergency medicine and in other specialties that we come in contact with, i.e. all of them. You know, this did eat up a considerable amount of time and discussion and brain power at the New York City Poison Control Center during the latter half of my fellowship. I can't say there was a really satisfying outcome other than the fact that the cases seem to decline on their own naturally when the market forces dictated that, you know, vitamin E acetate was no longer a favorable adulterant to have in these THC containing solutions. So hopefully this is in the rear view window and we won't have to consider it again. And hopefully in Canada, you didn't consider it too much in the first place because, you know, it basically never happened.
Thank you, Josh.
Great, thank you, Josh. Okay, I don't think we have any more questions. Christine found a study suggesting that vaping did increase your risk of COVID. Good to know. Okay, thank you, Mariam. That's the end of rounds this week. Next week is interactives, and then the week after we have our rescheduled guest speaker event with Ken Milne from the Skeptic's Guide to Emergency Medicine. So hopefully we'll see lots of you joining us then. But that's it for today. So goodbye.
Bye.